acute hepatitis. Aspen Carpenter, Andrew Andres, Matt Fredrickson, and Chelsea Haley. Pathophysiology. Hepatitis is inflammation of the liver. The most common cause is a virus, but it can be caused by substances like alcohol, chemicals, types of medications, autoimmune, and metabolic issues. In acute viral hepatitis, the virus attacks hepatocytes either through the direct action of the virus or an immune response to the virus, which leads to many dysfunctions of the liver. Different bodily functions are compromised, which include bile production, blood glucose, protein metabolism, and detoxification of drugs, hormones, and metabolites. Once the infection has been resolved, the cells of the liver can start to rejuvenate and replenish themselves. If there are complications, further liver dysfunction will result, and damage may be irreversible, and that can lead to liver failure or death. If there aren't any complications, then the patient may resume a normal life, and the liver will return to normal appearance and function. Clinical manifestations. Some patients may exhibit right upper quadrant pain and possible flu-like symptoms because of the liver inflammation. Many patients don't have any signs or symptoms of being infected with hepatitis. Depending on the type of hepatitis, the acute phase may be between 1 to 6 months. The acute phase is the time where the infection is at its highest or most potent. The compromised liver has an excess of bilirubin, which causes jaundice and a darker color of urine. Pruritus sometimes accompanies jaundice and can be very irritating for the patient. Most patients do recover, and even more so if they are infected with type A. Some patients may also experience a relapse in the infection. The mortality rate is less than 1%, but patients can still have complications, especially if they have underlying health issues. Complications include acute liver failure, chronic hepatitis, cirrhosis of the liver, portal hypertension, and hepatocellular carcinoma. Diagnostic testing. So you have your liver function tests, which are your aspartate aminotransferase, your alanine aminotransferase, your serum bilirubin, your alkaline phosphatase, your G-glutamyl transpeptidase, and your serum albumin. You also have coagulation studies, such as your prothrombin time, or PT, and your INR. And there's other serum tests as well, such as the FibroSure or Fibro test. Diagnostic testing continued. There's hepatitis testing, such as for hepatitis A, which has anti-HAV IgM antibodies. Hepatitis B, which has HBsAg. You can read all of those. There's hepatitis C, and you can also do imagery, such as ultrasound elastography or fibroscan. Treatment. There's currently no specific treatment for acute hepatitis. Typically, it can be managed at home with emphasis on rest to promote liver regeneration. There's also a big emphasis on proper nutrition, avoiding alcohol. Drug therapy can also be used, but it depends on what type of hepatitis the patient has. If it's hepatitis A, there's no treatment of the acute infection. The immune globulin, or Ig, in 1 to 2 months, passive immunity is given after 2 weeks after exposure. Hepatitis B, treatment of severe hepatitis and liver failure is what it entails. Primary nucleoside and nucleotide analogs decrease viral load and liver damage. There's HBV vaccine and hepatitis B Ig, and that's for post-exposure prophylaxis. For hepatitis C, you can monitor or direct-acting antivirals. Supportive care, there's antihistamines for generalized pruritus, and antiemetics such as promethazine or Phenergan, ondansetron, and Compro. You can also do vaccinations. There's a prophylaxis for hepatitis A and hepatitis B, and they have proven to be 95% effective. other treatments, such as milk thistle or silymarin. So they did a study and they found that it may promote the growth of liver cells and that it may inhibit inflammation. However, these findings came from small studies that were not very well designed. In better designed studies, they found that hepatitis C patients who took milk thistle had fewer and milder symptoms than the standard antiviral treatment. They did notice, however, that there was no change in the virus activity or in liver inflammation. Some potential complications of hepatitis are fibrosis, which is the most common complication because of the inflammation. If the inflammation lasts for too long, it can cause damage to the liver. There's also acute liver failure, because the acute inflammation in the liver can cause the liver to stop working properly. Portal hypertension can occur because part of the liver's job is to filter blood, and if your liver is not working properly, it can cause an increase in the pressure. And hepatic encephalopathy can occur because your liver is not filtering out all of the toxins that it normally does, and those toxins can build up in the brain. Nursing diagnosis number 1. So this is the diagnosis we decided was the most likely to cause harm to our patient or to kill them. We came up with impaired liver function related to hepatitis infection. First thing you want to do for this patient is to assess for the presence and the degree of jaundice using a standardized scale. Once you've determined that they are in fact jaundiced, then what you can do is provide 2,500 to 3,000 milliliters of fluids per day. Now this can either be oral or via IV, whatever the patient can tolerate. The idea here is that you're going to help dilute some of that bilirubin, help clear up the jaundice, make it a little easier on the patient's body. You also want to provide foods that are high in protein and vitamins. The idea behind this is you're going to help the liver regenerate by giving it everything it could possibly need. And perhaps most importantly is you want to teach the importance of hand hygiene to your patient so that they don't spread the infection to others. Since this is typically how hepatitis is spread, either a patient doesn't know they have it or they don't wash their hands well enough. They spread it to family members. So for our second nursing diagnosis, we came up with imbalanced nutrition, less than body requirements, related to anorexia and nausea. And the first thing you want to do for this patient is to assess their nutritional status to determine if they are anorexic or if they're nauseous, vomiting. You also want to assess the degree to which they're able to tolerate foods. And along with that is you want to provide high-calorie, nutrient-dense foods, since they aren't likely to, have an appetite to be willing to eat anything that you can get them to get down. You want it to be, the most bang for your buck, so to speak. And along with that, you want to administer anti-nausea medications if they're prescribed. Once again, this will help hopefully stimulate appetite. And then you also want to teach good oral hygiene habits to your patient, such as brushing their teeth, since this can improve the taste of food, helps the mouth feel refreshed. It also stimulates the salivary glands, and hopefully it'll also help stimulate their appetite. For our third nursing diagnosis, we came up with activity intolerance related to fatigue and weakness. And the first thing you want to do for this patient is to assess for the appropriateness of activities and bed rest orders. If you have a patient that, can walk around the unit, you don't want to put them on bed rest. But conversely, if you have a patient that is very weak, is a fall risk, you don't want to be trying to get them up and moving around. You do, however, want to gradually increase activity as tolerated by the patient. So say your patient is on bed rest, you can do passive range of motion exercises. You can gradually increase the number of repetitions of this. If your patient can get up and walk around, even better. You can, slowly increase the distance they're walking, maybe one more lap around the unit, a couple more laps, that sort of thing. You also want to prescribe or administer any prescribed pain medications before your patient begins activity. Hopefully this way they'll be more inclined to get up and move around. And you want to do this roughly 30 minutes before they start their activity and give the pain medication a chance to work. And lastly, you want to teach the importance of mobility to help prevent constipation. So your patient is able to get up and move around, but they say they're too weak or they're in too much pain. You can explain to them that if they become constipated, their abdomen's going to become distended, it's going to be even more painful, it's going to make things worse for them and kind of spiral out of control from there. And here's our references, guys. Thanks for watching our presentation, and hopefully we'll get some good feedback from you. Thank you.